Welcome to today's deep dive. Um, right now, half of all women who have had a vaginal birth are experiencing a physical change that, frankly, fundamentally alters their daily lives and their intimacy.
Yeah.
But, and this is the crazy part, an astonishing 80% of them will never, ever mention it to their doctor.
Right. It's staggering, really. The gap between how common this is
Hmm.
and how rarely we actually talk about it.
Exactly.
That silence leaves so many women isolated. They just quietly assume that, discomfort or incontinence or just a loss of physical sensation. They think it's an inevitable penalty for getting older or having kids.
Well, we really want to break that silence today. We are looking at vaginal laxity and the loss of structural tone. Specifically, we're examining whether a really buzzy, innovative procedure, you've probably heard of it, it's known as the O shot, can actually help reverse this.
Right, because there's a lot of marketing hype out there.
So much hype. So to figure out if this is a genuine medical breakthrough or just, clever branding, we are analyzing a really dense stack of sources today. We've got peer-reviewed medical journals, clinical studies on regenerative medicine, systematic reviews.
And the actual clinical protocols for the procedure itself, which is great.
Yeah. Our mission is to objectively evaluate the science behind this idea of using a patient's own blood plasma to regenerate intimate tissue.
But before we can evaluate the solution, we have to kind of establish the exact nature of the problem, right?
Yeah.
The sources define vaginal laxity, or VL, as a feeling of looseness
Okay.
or an exaggerated capacity for distension. It basically leads to a significant loss of physical friction during intimacy.
Which is a big deal.
Huge deal. But looking at the literature, it becomes really clear that this is a symptom of underlying tissue failure. And it originates from two very distinct pathways.
Right, the first pathway being mechanical trauma. Because during a vaginal delivery, the pelvic floor undergoes just extreme physical stress. The sources specifically point to trauma in the levator ani muscle group,
Yeah, the levator ani.
which, if you picture it, essentially acts as the supportive hammock for all your pelvic organs.
That's a really good visual.
And the more vaginal deliveries a woman has had, or, the larger the babies, the higher the likelihood of stretching or tearing those exact muscle fibers.
Right, to the point where they can no longer contract properly.
Right. And then what's the second pathway?
So the second pathway is hormonal. This ties into the natural aging process and menopause. The medical term used in the literature is genitourinary syndrome of menopause.
GSM.
Right. Exactly, GSM.
Right.
Some of the sources also refer to it as vulvovaginal atrophy. Basically, when a woman experiences a systemic drop in estrogen, it triggers a severe cascade of physiological changes in the vaginal mucosa.
Then the mucosa being the inner lining, right?
Yes, the inner lining of the vagina, which actually functions a lot like the tissue inside your cheek.
Wow, okay. And the physiological breakdown detailed in the sources is intense. Like, without sufficient estrogen, the body just stops producing dermal collagen in that area.
It just shuts down.
Yeah. The epithelium, so the surface layer of the tissue, becomes incredibly thin. The local vascular network shrinks.
Which means blood flow drastically decreases.
Exactly. Even the natural vaginal pH shifts higher, making the environment more alkaline. And all of this combines to cause severe dryness, burning, and painful intercourse.
Which the medical community calls dyspareunia.
Right. And I have to imagine the psychological toll of this is just profound.
Oh, it really is. The literature draws a direct line between vaginal laxity and female sexual dysfunction, or FSD. Women report experiencing severe emotional distress, a drop in libido, and an inability to achieve orgasm.
Wow.
Yeah. I mean, this isn't just some cosmetic tightness issue. It's highly, highly functional.
Functional. Okay, because some people might hear laxity and think it's just aesthetic.
Not at all. Beyond intimacy, the loss of structural tone correlates really strongly with pelvic organ prolapse.
Oh, that's where the bladder or the uterus physically descends into the vaginal canal, right?
Exactly. Because there's just a lack of support.
Yeah.
And it also leads to stress urinary incontinence.
So the sources make it undeniably clear that we are dealing with a fundamental loss of cellular matrix, of hydration, and vascular support. Which brings us to the proposed fixed platelet-rich plasma, or PRP.
Right, the O shot.
Yeah. I was actually trying to visualize what happens to this tissue over time, and the best analogy I could think of is like an old, neglected garden.
Oh, I like that.
Yeah, so the soil is just parched, cracked, and totally dusty because the underground sprinkler system, which is the vascular network, has dried up.
That captures the anatomical reality perfectly.
Yeah.
Because when the tissue loses its vascular network, It completely loses its ability to stay hydrated and elastic from the inside out.
Right, and traditional treatments, like using external lubricants, they're basically just pouring a bucket of water on that cracked topsoil.
Temporary relief?
Exactly. It provides temporary relief on the surface, but the water quickly evaporates because there's no root system to hold it. The underlying architecture is still dead.
Which is exactly where PRP comes in. The goal is to go deep into the soil and actually regrow the roots and that internal sprinkler system.
So how does that actually work biologically?
Well, the biological basis of PRP relies on the fact that it's an autologous treatment.
Meaning it comes directly from your own body.
Yes, specifically your blood.
Yeah.
The patient comes into the office and they just do a standard blood draw from the arm.
Okay, simple enough.
Then that vial is placed into a specialized FDA-approved centrifuge.
And the rapid spinning of the centrifuge is what separates the dense red blood cells from the plasma.
Exactly. What remains is this concentrated golden liquid. The studies indicate this extracted plasma has a platelet concentration 5 to 10 times higher than what you'd find in normal circulating whole blood.
5 to 10 times, that's a massive concentration.
It is, because platelets are basically the body's microscopic first responders. When you get a cut or you suffer some kind of tissue injury, platelets rush to the site and they release alpha granules.
Alpha granules, okay.
Yeah, and those contain an absolute army of growth factors. So by concentrating them in the plasma, you're harnessing a massive dose of these healing agents. The sources actually identify about 35 crucial growth factors released in this process.
35, wow. And 3 of those really stood out in the literature because of what they specifically do. You have vascular endothelial growth factor,
EGF.
epidermal growth factor, and platelet-derived growth factor. And the cool thing is they don't just sit in the tissue. They actively command the surrounding cells to change their behavior.
Right, they act like biological managers. They stimulate cell proliferation and promote the synthesis of collagen III.
Which provides that physical scaffolding the tissue lost in the first place.
Exactly. But most importantly, they induce a process called angiogenesis.
And angiogenesis is the formation of brand new blood vessels. So returning to that garden analogy, injecting this concentrated plasma is like planting the seeds that physically grow a new root system.
And a new sprinkler system beneath the soil.
Yeah. Once those new blood vessels form, they bring continuous natural blood flow back to the area, which rehydrates the tissue naturally from the inside out.
And it doesn't stop there. They also aid in nerve regeneration, returning sensitivity to areas that have, frankly, just gone numb over time.
So with that mechanism of action established, we have to look at how this liquid is actually delivered, because you can't just take a pill to fix localized tissue atrophy.
No, you have to physically deploy the platelets into the damaged area, which is where the O-shot protocol specifically comes into play.
Right. The sources specify that the O-shot or orgasm shot is a defined, trademarked protocol. It was developed by Dr. Charles Runels.
That's right.
And it dictates exactly where the PRP must be injected to treat vaginal laxity and sexual dysfunction. The injections specifically target the clitoris and the anterior vaginal wall, mostly the distal portion.
Right. And for you listening, distal just means the outer portion of the vaginal wall closest to the opening. It's frequently referred to as the G-spot area.
Okay, but why both areas?
The reasoning is anatomical. The clitoris is not just a surface organ.
Right, it's huge internally.
Exactly. It has internal structures that wrap completely around the vaginal canal. So by treating both the external clitoris and the anterior vaginal wall, the growth factors can permeate the entire clitoral complex.
And all those surrounding support structures.
Exactly.
Okay, I have to pause here, though, because, and I'm sure you listening are thinking the same thing, the sheer idea of this is deeply intimidating.
Oh, absolutely.
We are talking about taking needles and injecting liquid into literally the most highly sensitive nerve clusters in the human body. The initial reaction is just terror at the thought of the pain.
And the clinical protocols heavily emphasize pain management for that exact reason. They don't go in blind. A potent medical-grade topical numbing cream is applied to the area for about 20 minutes beforehand.
Okay.
Or a localized anesthetic block is used. The literature reports that because of this preparation, patients typically experience only a mild pinch.
It's just a mild pinch.
Yeah, or like a brief stinging sensation
Right.
rather than severe pain. The whole procedure takes maybe 30 to 60 minutes.
Okay, but the most surprising part to me was the recovery time in the clinical guidelines. There is 0 downtime required.
None at all.
The sources explicitly state that patients can resume normal activities, including sexual intercourse, on the exact same day.
It's pretty incredible. The dosing amounts outlined in the studies also vary depending on what the physician is trying to treat.
Okay, break that down for me.
Sure, if the primary goal is treating sexual dysfunction, poor lubrication, or laxity, the standard protocol calls for injecting about 2 milliliters of PRP into that distal anterior vaginal wall.
But the sources noted a totally different protocol for stress urinary incontinence.
Right. For women who involuntarily leak urine when they laugh or cough or exercise, the physician injects a much larger dose.
Like 5 to 6 milliliters, right?
Exactly. And that goes directly into the periurethral area.
The tissue directly surrounding the urethra.
Yes. Because the mechanism there is structural reinforcement. The urethra actually relies on the surrounding vaginal wall to hold it shut when intra-abdominal pressure increases.
Like when you sneeze.
Right. When you sneeze, that surrounding tissue has to support the urethra. When it becomes lax, it fails to support it, resulting in a leak. So flooding the periurethral area with PRP thickens and strengthens that supportive tissue.
Or restoring that physical barrier that keeps the bladder neck closed.
Exactly.
And as for the safety profile, the studies are highly reassuring. Because the injected material is entirely autologous, derived from your own blood, the risk of tissue rejection or allergic reaction or some kind of foreign body response is virtually non-existent.
You can't be allergic to yourself.
Right. The adverse effects reported in the literature are basically just localized to the injection itself. We're talking minor, temporary spotting, maybe some mild swelling or slight bruising.
So the theoretical mechanism makes sense, and the safety data is solid. But the ultimate test is whether the clinical data proves that the O-shot actually restores tone and function.
And researchers quantify these results using standardized, validated medical questionnaires.
Right, they don't just guess.
No, the two primary tools mentioned in our stack are the Female Sexual Function Index, the FSFI, and the Vaginal Health Index. And these measure very specific parameters before and after treatment.
Things like levels of arousal, natural lubrication, degrees of pain, and overall satisfaction.
And across multiple studies utilizing these indices, the clinical outcomes show dramatic improvements. Patients are consistently reporting increased natural lubrication, thickened vaginal mucosa.
Heightened tactile sensitivity.
Yeah, and more frequent, intense orgasms.
There's actually one specific observational study in our stack that provides a fascinating look at how PRP works in really severe cases.
Oh, the one with the surgical band.
Yes. Researchers were treating women with grade 2 to 3rd vaginal relaxation, which is a fairly significant level of laxity. To fix it, they used a combination therapy. They inserted a human acellular dermal matrix, an HADM.
And then combined it with PRP. But explain the HADM real quick.
Sure, the HADM is essentially a biological scaffold. It's a piece of decellularized tissue used by surgeons to act as a structural beam. They place it in the vaginal wall to physically tighten the opening, kind of acting as a biological band.
Right, but the researchers noted a major complication with that. The surgical band provided great structural support, but it's completely avascular.
It has no blood vessels of its own.
Exactly, it's just a dead structural beam. So because of this, patients who only received the HADM band suffered from severe vaginal dryness for months after the procedure, because the tissue surrounding the band was literally starved of nutrients and blood flow.
The physical opening was smaller, but the tissue health was deeply, deeply compromised. The surgical intervention alone failed to restore the functional elasticity and hydration of a youthful vaginal wall.
So the researchers adapted. After placing that HADM band, they injected PRP directly into the surrounding tissue.
And those growth factors from the PRP induced angiogenesis.
Yeah.
They grew a whole new vascular network that integrated with the artificial scaffold.
And the results were highly successful. The PRP nourished the mucosa, it completely resolved the surgical dryness, and restored sexual function, all while maintaining the structural tightness provided by the band.
It's incredible. It proves that treating laxity requires a dual approach. You can't just suture the anatomy closer together. You have to cultivate a living, hydrated, cellularly active environment.
Okay, but I want to push back heavily on the current medical consensus here.
Okay, let's hear it.
Because the clinical results we just discussed sound incredibly effective, yet multiple systematic reviews in our stack explicitly classify PRP for vaginal health as an investigational or experimental therapy.
Yeah, they do.
If it works this well, with zero downtime and practically no risk of allergic reaction, why hasn't it been universally adopted as the absolute gold standard by the broader medical community? Why is it relegated to, cash pay procedures at med spas and boutique clinics?
That's the big question. And it really comes down to the rigorous standards required by major medical boards versus the reality of clinical innovation.
What do you mean?
Oh, the medical community relies on massive, double-blind, placebo-controlled, randomized trials to establish a true gold standard. These trials cost millions of dollars, and they are typically funded by pharmaceutical companies.
I see.
Yeah, you cannot patent a patient's own blood. So the massive financial incentive to fund those definitive trials simply isn't there for big pharma.
So the data we have is primarily from smaller, independent clinical studies.
Exactly. And those smaller studies suffer from methodological inconsistencies. The biggest issue highlighted in the systematic reviews is a lack of standardization.
Like how they process the blood?
Right. Different clinics use different brands of FDA-approved centrifuges. They spin the blood at different speeds for varying lengths of time. So one clinic might yield a plasma with a massive concentration of platelets, while another clinic's process might yield a much, much weaker concentration.
Wow. So without a standardized formula, the major medical societies cannot rubber stamp the procedure because they can't guarantee what exact dose of platelets a patient is actually receiving at any given clinic.
Precisely. The science of PRP is completely valid, but the application across the industry is still too variable for a universal textbook endorsement, which leaves patients having to navigate an evolving landscape of treatments where the O-shot is really just one of several options.
So looking at the traditional alternatives for vaginal laxity, surgical options are definitely the most established.
Right. Procedures like vaginoplasty or perineoplasty.
Yeah, those involve cutting away excess tissue and physically suturing the underlying muscles closer together.
But while surgery undeniably tightens the physical opening, the sources heavily emphasize the associated risks. Surgery carries a high risk of scarring, which can cause severe permanent dyspareunia.
Painful sex.
Right. There's also the risk of developing fistulas, which are abnormal holes or pathways that form between two organs, like between the vaginal wall and the rectum or bladder.
Which sounds awful. And as we learned from the HADM study, surgery does absolutely nothing to improve blood flow, nerve sensitivity, or natural lubrication. If the tissue is aged and dry, suturing it tighter just creates a tighter, dry space.
Exactly. And this functional gap has really driven the rise of non-surgical energy-based devices, or EBDs.
These include radiofrequency treatments like Thermiva or VVEV, as well as fractional CO2 lasers. And the mechanism for these devices is honestly fascinating. They use controlled heat energy to create microscopic injuries deep in the vaginal tissue.
Right. The body detects this thermal damage and immediately rushes to produce collagen as a healing response.
Which tightens the tissue. The sources actually note a growing trend of practitioners combining these heat therapies with PRP.
Oh, that makes sense.
Yeah, they use the laser to trigger the initial healing response and then inject the PRP to flood the area with the necessary building blocks to actually construct the new tissue.
For women dealing specifically with the hormonal fallout of menopause, though, the traditional first-line treatment is localized, topical estrogen therapy. This directly replaces the missing hormone in the vaginal tissue.
But our sources feature a comparative study that pitted topical estrogen directly against PRP injections for treating postmenopausal vaginal atrophy.
And what did they find?
The results showed that PRP was a highly effective alternative to the hormone creams. And this is a massive revelation for a specific population.
Yeah, like breast cancer survivors.
Exactly. Breast cancer survivors or women with a history of blood clots, they're often strictly advised to avoid any form of hormone therapy, even localized creams. So for them, PRP offers a completely natural, hormone-free method to restore tissue health.
That's incredible. And the versatility of these localized growth factors is further demonstrated by their application in severe dermatological conditions. The literature notes that this exact same PRP protocol is actually being used to treat lichen sclerosis of the vulva.
Wait, lichen sclerosis? That's a chronic condition, right?
Yes. It causes the skin of the vulva to become patchy, extremely thin, inflamed, and just intensely itchy. It can lead to severe structural scarring if left unchecked.
So how does PRP help that?
By injecting the concentrated platelets directly into those lesions, the growth factors essentially reprogram the localized immune response. They heal the damaged tissue and provide profound symptomatic relief.
Wow.
It proves that this mechanism extends far beyond just aesthetic or sexual enhancement. It is genuine, deep tissue repair.
So, synthesizing all this clinical data, the ideal candidate for the O shot emerges pretty clearly. It's a highly appropriate intervention for women seeking a non surgical, hormone free solution for mild to moderate vaginal laxity, decreased sensation, vaginal dryness, or stress urinary incontinence.
However, the sources are very clear on its limitations.
Right.
If a patient is suffering from severe pelvic organ prolapse, where the mechanical failure is so extreme that the organs have actually descended out of their proper anatomical position, PRP alone cannot reconstruct that kind of structural collapse.
In that case, surgical intervention would likely be necessary to actually repair the physical hammock of the pelvic floor.
Exactly. But for the vast majority of women experiencing the common degradations of childbirth and aging, PRP offers a really compelling, low-risk tool to intervene before structural collapse ever occurs.
The ultimate takeaway from our deep dive today is one of empowerment. Vaginal laxity, the loss of intimate sensation, and urinary incontinence are incredibly common, anatomically understandable conditions.
They happen to so many women.
They do. But the clinical landscape is shifting rapidly. The era of just suffering in silence and assuming these changes are permanent, it's over. The regenerative capabilities of your own blood are actively being utilized right now to stimulate collagen, regenerate nerve pathways, and rebuild the vascular networks that sustain intimate health.
And having a firm grasp on the mechanics of these advancements gives you the vocabulary to advocate for yourself. It allows you to approach your healthcare provider not just with a list of symptoms, but with informed questions about regenerative options.
Which helps to finally dismantle the stigma surrounding female sexual health.
It really fundamentally changes how we view the aging body. It leaves you wondering, if we can successfully extract the concentrated growth factors circulating in our veins, manually deploy them to desiccated tissue, and instruct them to regrow blood vessels and nerves in our most sensitive organs.
Right. What other degenerative, age-related conditions might we soon be able to reverse simply by rerouting our body's own internal repair kits to where they're needed most?